Hi, Ankita. Dr. Gagandeep joining, sir?
Not responded. I'll just call him up now.
We'll wait for a couple of minutes.
Oh, he's not responding to call.
We'll start.
I think Gohan, you can go ahead now.
Okay, sir. I'll start with the good evening, respected chair, panelists, convener, chair, panelists, and attendees. On behalf of the Neuro Rehab subsection of the Indian Academy of Neurology and the Indian Federation of Neuro Rehabilitation, we welcome you to the public awareness program on motor neuron disease on Global MND Awareness Day and Yoga for Brain Health on International Day for Yoga. The theme of our program today is Yoga for Brain Health and Discerning the Beacon of Hope in ALS, multidimensional management of ALS. And since the program is aimed to increase the awareness for the public, I kindly request the panelists that we shall keep the discussion in simple terms without the use of medical jargons so that it reach the patients, caregivers, and the public. Now, to start with the introduction of the chair and the convener. First, to introduce the chair for the session, Professor Dr. Nirmal Surya, sir, a person who requires no introduction, and he is well known across the neurology and the neuro rehab specialties. He is chairman of the Surya Neuro Center and associate professor of the Bombay Hospital and Medical Research Center. He is a recipient of the Kenneth M. Viste Junior Patient Advocate of the Year Award by the American Academy of Neurology, founder, trustee, and chairman, Epilepsy Foundation of India, founder, president of IFNR, past president of Indian Academy of Neurology. He is president of the 10th WCNR that was held in Mumbai. He is regional vice president of WFNR. He is past president of AOSNR. He is president-elect of the Indian Stroke Association, a member at large of the Presidium WFNR, and he is chair of the Developing World Forum WFNR, and he is past presidents of MAN and BNA. Next, introducing our convener of the session, Dr. Abhishek Srivastava, sir. He is a neuro rehabilitation specialist and director, Center for Rehabilitation, Kokilabin Dhirubhai Ambani Hospital, Mumbai. He has over 60 publications. He is specialized in botulinum toxin for spasticity, rehab, robotics, and hyperbaric oxygen therapy. He is a WHO fellow for TBI. He is chair for the SIG Multiple Sclerosis WFNR. He is secretary of the IFNR. He is convener of the Neuro Rehab, chair of the Neuro Rehab subsection of the IAN. He is organizing secretary of the WCNR 2018, and he is an IAPMR gold medalist. So next we will introduce we will proceed with the first session for the day, that is the International Day for Yoga. we will introduce a faculty for the expert and faculty for the International Day for Yoga, Dr. Sanjay Phadke, sir. He is a senior consultant in neuropsychiatry, Jahangir Hospital and Dinanath Mangeshkar Hospital. And he is formerly associate professor and co-investigator of ICMR, Center for Advanced Research. He is principal investigator of more than 50 international clinical research projects, including clinical trials of new medicines. He is chair for the Center for Behavioral Medicine, which is umbrella organization for neuroscience of yoga, and member official delegation of the Government of India, First International Conference on Yoga. He was the presenter of Neuroscience of Yoga. Vaibhav Summit organized by the Prime Minister's Office, founder chair, Indian Psychiatry Society, National Medical Association's Task Force on Mind-Body Medicine. Over to you, sir. Can we please have the talk?
Sure. Can I share my PPT?
Yes. Yes, sir.
Okay. Is it visible?
Yes, sir, it's visible. Put it on slideshow mode.
Visible?
Yeah. Yes, sir. Yes, sir.
Thank you. So at the outset, it is absolutely wonderful. My pleasure, great pleasure to be, as I said, in the august company of Professor Surya, Abhishek ji, and our young friend Gohan. And it's a wonderful program and activity wherein you got the medical people as well, the patients and their families together. So let me give a very brief and then we can have some discussion on this. So the title is Yoga for Brain Health. And I would like to introduce you to this idea that how to make this more practical for people, deliverable to larger masses, which is the yoga-based neuroregulation training. So as we all are aware that society has expectation to receive affordable and accessible care and better quality of life. And perhaps this is very important in the domain of neurorehabilitation. With people aging, more people getting the chronic neuro problems, we know that this is a very important unmet need, so to speak. There are a large number of patients who are waiting to receive quality services, and it really calls to my mind for approaches which are scalable, which we can deliver to large number of our clients. On the positive side, so on one hand, we have these challenges. On the positive side, several scientific advancements, as we know, in the neuroscience and the mind-body medicine. And most importantly, perhaps even more so after the COVID, people's eagerness to be active participants in their own healthcare. They are much more motivated today than perhaps any other time. So people are very interested, very eager, and we must capitalize on this, that they want to pitch in a big measure for their own health. So what I'm going to do is I'm going to have a very quick overview of key ingredients of neuroscience of yoga and the opportunities which it offers to us in a more structured way for the aftercare and neuro rehab, as well as promotion of brain health for both purposes. So on one hand, for the patients, on the other hand, for people like us, those who are now gradually aging and who would like to retain their brain health. So the start of this story, which has been, you can say, our motivation, it dates back nearly to 15 years, and you may perhaps be aware, many people may be aware that the US government, it set up a commission of scientific people, medical people, statisticians, and they looked at whole 50 years of research of yoga meditation, which was available globally. And they concluded that on one hand, on the positive side, that there is a positive signal, beneficial effects of these techniques. But at the same, this report also points out that many uncertainties surround practice of such mind-body techniques. People have many different techniques. There is no commonality of a proper theoretic perspective, and methodological quality of the studies which were conducted was generally not up to the mark. The extent to which pharmacological studies are carried out, the quality of pharmacological studies, if compared, wasn't so great for these non-pharmac studies in general. So what in essence it tells us is that the scientific people feel a bit confused as to understand as to what exactly is happening, when yoga meditation is being practiced, and they would be much better off if there is a better clarity, a better formulation in neurologic terms, so that we have an opportunity to apply these methods in a more scientific way. Where do we stand? So that was nearly 10-15 years ago, this whole commission report. And my question is that do we today in 23 have any better understanding of neuroscience of yoga and its application for health? So the answer is yes, we definitely stand better in terms of the mechanisms involved. A lot of studies in the meantime have happened, and for the sake of everyone's understanding, I have put it in basically 3 headings. So what does the practice of yoga do to the chemicals in the brain, neurotransmitters as well as the hormones? So it basically does 2 set of things. First is, we can in general way say that it enhances beneficial transmitters. GABA, as we know, gamma aminobutyric acid is one such transmitter. And in fact, many of the medicines which are used in neurology, for right from epilepsy to pain management in neuropsychiatry, many of these medicines, they actually work through this GABA system. Yoga also works through this system. So it enhances this GABA system. It also enhances BDNF, brain-derived neurotrophic factor, is like a fertilizer to the brain. It promotes the brain cells, the brain connectivity. By fertilizer, we all commonly understand, that it promotes the growth. So it has a positive role. GABA has a very important role. So it enhances these beneficial transmitters. And we know that sometimes uncontrolled, prolonged secretion of cortisol, the steroids inside our body, it is not so beneficial, because it thins the brain. So what yoga does is that the practice of yoga enhances the beneficial chemicals, and it controls or it regulates the not so beneficial ones. So this is one set of mechanisms. A second set of mechanisms is that we know that there are many different brainworks, very different networks in the brain. These networks basically sort of regulate the different functionality in the brain, and which is disturbed in different disease conditions. So they regulate, they normalize these brain networks, the yoga practice. And very importantly, it even leads to a prolonged practice, even leads to anatomical, physical changes, positive physical changes in the brain. A lot of people nowadays know this term called as neuroplasticity, which means that a positive structural change happening in the brain, and a neuroprotective effect, which happens in the process of aging, the brain thinning. So there is a neuroplastic process, there is a neuroprotective effect. So we can say that yoga has a positive effect on functioning as well as the structure of brain. And a third set of things, we know that this system called as autonomic nervous system, which is the most important, you can say, link between the brain and which connects to all the internal organs, synchronizes all the organs, regulates all our vitals, regulates the blood pressure, regulates the heartbeat, is involved in regulation of the digestion, and practically all vital functions. This has a very important role in all the non-communicable diseases, including the neurologic diseases. And very interestingly, very recently published in a very high quality journal, we all know, I think even patients know, that Nature is considered as one of the topmost science journals. And in a very latest issue, I saw this, that previously we believed that the parts of the brain which regulate movements only regulate the muscles. So it's on the left-hand side, the 1948 view of understanding the way the brain controls the movements. But now we have the latest view, 2023 view, which shows that how the movements in the brain are very interlinked, intertwined with all the vital functions also. So it's not only the movements of our muscles and our skeleton, but it's also very intimately involved with regulating all the vital functions, as if everything is a nice orchestra, everything happens in a nice symphony. We had a lot of experience working with this autonomic nervous system last 10 years or so as part of this Indo-German collaboration. We have had the opportunity to do several types of studies involving the autonomic nervous system. And in a word, if I have to tell you the results, that yoga basically is a very powerful modulator of autonomic nervous system, and different sort of activities within the yoga fold, we know that yoga has many different set of activities within it, asana, pranayam, and the more meditative aspects. They create differential modulation. So at will, we can modulate this autonomic nervous system and in many different ways. This knowledge, of course, in future is going to be of great help for us to design specific kind of more tailor-made interventions for people. We also did some of these, you can say, interesting experiments wherein we looked at people in action, measuring their muscles, measuring their EEG activity when they are doing different yoga processes. We discovered that yoga basically is a process of relaxation in action. It's a very unique skill. When an action is happening, relaxation is also happening. Something which doesn't happen ordinarily in our routine exercises, which we do. As we know that last 10 years, 12 years, and this is one of the first review articles by Mishra and colleagues, which they published in Annals of Indian Academy of Neurology, the Indian Neurology Journal, and wherein they reviewed the therapeutic value of yoga in various neurological disorders. I would say this was one of the first reviews to appear in the year 2012. And thereafter, in last 10 years, there have been many studies, which more understanding and better improved methodologies in many of these disease entities, these domains. So degenerative diseases, Alzheimer's disease, dementia, movement disorders, specifically Parkinson's disease, epilepsy, stroke. And just now, as Professor Surya informed, he has been involved in the epilepsy studies and the pain studies, headache studies. Dr. Srivastav currently involved with that, multiple sclerosis, chronic pain, including neuropathy and fibromyalgia. And of course, the brain health and aging, various studies which have demonstrated a beneficial effect on the memory, cognition, sleep, mood, various aspects of the brain health. Now, the main challenge in this whole context is we know that if it works in a good, nice way, question which has been on our mind is that how to make it more practical, safe, and effective, so that, again, as I said, that it could go to more people. So we did one of our pilots. We have been on this activity last 5 years or so, and we presented one of our first pilots in this World Congress, which was organized by Professor Surya in 2018 Mumbai, which is a self-paced yoga asana learning and home practice, which improved quality of life and cognitive functioning in Parkinson's disease. And we followed it up, this particular pilot study. And this is my practically last slide, slightly busy slide, but I will try to explain you this, that how to making use of all the knowledge that we have today, that how therapeutic application of yoga could be made more practical. And that is where we have trying to formulate this whole practical translation. What if you want to make use of a term which is self-explanatory, we like to call it a yoga-based neuroregulation training, because yoga is finally an activity which is helping you learn that how to regulate your own nervous system. We know that yoga is not just the yogasana. A lot of people criticize nowadays that yoga is not just yogasana, try and apply more benefits of it. We know that Ashtanga yoga is a very wholesome mind-body activity. And the translational challenge therefore was to how to, without dilution, how to incorporate on one hand the cardinal principles of classical yoga, but at the same time make it simple enough, suitable for patients. We know that patients have limitations of mobility, patients have limitation of cognition, they have pain, and above all, they have variable speed of learning. Their speed of learning may not be the same as normal healthy people. So we have to, within their own limitations, on one hand, we don't want to lose on the essence of yoga, but on the other hand, we want to make it simple and more accessible to all these people. So this regulation, neuroregulation, it broadly operates, you can say, at 3 levels. One is activities designed towards basically regulation of cognition. Second one is the autonomic and the neuroimmune endocrine axis. And third is the regulation of the biomechanics, the musculoskeletal one. Now, something special, one point just out of these, of course, there are many specialities here, but one point that I would like to highlight through this yoga cognition regulation, a very special feature of the yoga practice, even when you are doing yogasana, is an emphasis on the inner perception. or introception, technically called. Our perception of our own self, perception of our body at different levels. We know that we are luckily blessed with millions of sensors. Our muscles have sensors, our joints have sensors, our skin has sensors, our internal organs have sensors. Normally, we seem to not really be paying much attention to this whole information which comes in. So one of the first tasks which we do as part of your cognition is to gather this whole information feedback which is coming from our own self. And second part is that sort of making use of self-feedback to improvise the action, and that's how sort of learn based on that. So we make an action, get a feedback, try to improvise it, and that is how actually the whole process proceeds, and which actually makes the whole of yoga a very meditative activity. So it's not that yoga and meditation are two separate things, but in fact every action which is part of, because introception is the key element, you can say inner perception of our own self is a key element in the meditation, and which is part of yoga, and which has a tremendous healing potential, so to speak. Now we have to understand that this regulation is a training. It's not a therapy in classical sense, in the sense that, as I said, we would like people to learn this and then practice and improvise this practice on their own. And our piloting and work in last 4 or 5 years bears a testimony that people are able to do it. They enjoy it. So patient is an active participant, and they mostly need just handful of training sessions, which could be very self-paced, so every patient can adjust to one's own pace, and then they carry on the home practice. As a pilot, we even made a step-by-step practice video clip. We hope to do it more. So basically, the training plan, the basis of this training plan is a clinical assessment and a logic which guides selecting the whatever that we want, prioritize which of these three, the cognition or the autonomic regulation or the biomechanics, whatever we want to prioritize, depending on that, and then formulating the steps of neuroregulation, which is sort of becomes a personalized training. Of course, the trainer needs training, and that would be something we would look forward to next. And I actively look forward to work with all of you towards that how we are able to train ourselves more, train colleagues more, our colleagues more, and able to get this benefit to more people. Yoga-based neuroregulation training, it goes without saying, is of course also for promotion of brain health. So it is as much as for the neuro rehabilitation aftercare. In equal measure, in fact, people, those who are healthy, perhaps are in an even better position, even if they take it middle age onwards. There is a good evidence that although we might not have done much work for our own brain health until we are in our 50s and 60s, but even if we take it thereafter, there is a good enough neuroprotection which we can aspire to get. So thank you so much for this one. And just this last short point, that recognizing the need for enhancing the quality of research in this domain. A couple of years ago, the Prime Minister of India office, it took a initiative called as a Vaibhav, Vaishvik Bharatiya Vaigyanik Summit. So various aspects were covered in that. I was lucky in that part to be part of a panel which looked at this integrative health, and my role within that panel and the responsibility for which I have offered myself is to look at these new paradigms of mind-body assessments, health assessments, because some of our methods we found were not really good enough to capture the beneficial effect which these techniques will produce. So if we have an intervention, we should also have a method to assess the efficacy of that intervention, and that is something which we have been very actively been working on. Special thanks to my colleagues who have been collaborators and teachers in this whole enterprise. Professor Leena Fatke, who is primarily researcher in autonomic, and Reinhard Biogle, Bhavsar, B.N. Gangadhar, some of you perhaps know him. He was my teacher in immense, and now the president of National Medical Commission, and a very active promoter of all these ideas of integrative medicine and greater integration of yoga into our mainstream medical practice, and his junior, Professor Shivram. So thank you so much. This was very wonderful. I hope that this makes a sense to you, whatever I said, and we are open to have some questions, discussions, whatever you like. So over to you, Guhan. Can I put my slide share off?
Yes, sir.
Sir, I'll share, stop it.
Okay, thank you.
Now, next over to our chair, Dr. Nirmal Surya sir and convener Dr. Abhishek sir for few words on this International Day of Yoga in Brain Health.
Thank you very much, Guhan. On the auspicious day of International Yoga Day, when Mr. Modi has gone to America and he will do the honor of doing himself yoga with various dignitaries of US officers tomorrow morning, or rather tonight, would be a great honor. And this International Yoga Day has gained so much momentum. Honestly, last 40 years, we always tell the patient when come with headache or come with apprehension, anxiety, depression, we always say, okay, do yoga. But scientifically, studies has started coming, and as Dr. Farke has put it across, I was not aware. He has presented the paper in 2018 World Congress, and that was great. Not only yoga and the brain disorder in India, but in many other countries, it has gained the momentum. And there are many reports which are coming, particularly for Parkinson's. Dr. Singhal PDMDS group has done tremendous work in Iyengar team on Parkinson disease, and they found that various aspects of day-to-day life has improved. And I think I presented that one of the paper in China, 2019, and it was very well appreciated by Chinese because they were doing the Tai Chi, and they really were looking at how there can be a common link between yoga and Tai Chi. Abhishek and we have also worked in MS, and now we are working in epilepsy. So yoga has got scientific basis, has been told by Dr. Farke, and we are very happy that today two important days come together. Yoga, of course, has been celebrated all across the world, but motor neuron disease, which is a deadly disease, which we are going to talk after a few minutes, is something again falling on this day. And I hope that somebody can highlight this neurological disorder and its role in the future, how International Yoga Day can influence the long-term treatment in ALS and motor neuron disease. Thank you, Dr. Farke, for highlighting that we neurologists need to not ignore the yoga and have it in various neurological disorder where the long-term disability and treatment is being required for the disability. Abhishek.
Dr. Fatya, one small question for you.
Sure, please.
Among different types of yoga, as
Yeah.
you all know,
Yeah.
are there any recommendations which type of yoga is better for person with neurological disorders, and what should be the ideal intensity and frequency of practice for that?
Okay, so the short answer to this question is that because of paucity of time, you can say ever since this US government report was published, which said that the theoretic foundation is not clear, it has been our endeavor, of this Indo-German team to actually understand the yoga, what you can call through the bifocal lens. So on one hand, study the Patanjali Yoga Sutra as to what is the essence, what do they exactly imply, what do they ask us to do, and understand the processes in a sort of a neurologic sense. And I would say that we have succeeded to a great extent to decode that. So maybe whenever there is an opportunity, I would be very happy to share with you that as part of, say, practice of Ashtanga Yoga, that what exactly happens stated in neurologic terms, as in how the whole process goes, break it up into step-by-step sort of understanding, which has been one of our good ideas, and we definitely would like to share with all, because in that sense, if you look at it really, what you understand is that unlike the several schools of yoga which are there, in a popular way, I mean, different people have their own different schools, etc. But if you trace it back to the original sort of a base text, the Patanjali Yoga Sutra, they all follow the, you can say, the cardinal principles. For example, let us say look at asana. So what should be the ingredients of asana? What in neurological sense should be called as asana? So if you look at it that way, then it becomes easier for our application in medical usage, in that sense that there is no longer a school, but we have a scientific body of work available to us and we can make use of it in a therapeutic way. Of course, there are variations. People have brought in their own understanding to it, and different schools, for example, Angar school, I was also quite closely associated with the Angar school also, but at the same also, the practices which other people have brought to the fore. So that is completely right. But I can say we tried to therefore be agnostic, to these schools and rather looked at the whole, you can say, neurology. I would be very happy to share with you. So really, thank you so much, actually, thanks to Sonal and to Guhan, which brought me today together with you people. And as Surya sir said, it's auspicious occasion, maybe good beginning, of our more interaction and more partnership collaboration. Very nice. Thank you so much.
Thank you, Dr. A small comment, Dr. Farooq, a small comment, please.
Yeah, I'm sorry. I just wanted for my knowledge sake only. So like we talk about in today's time, like personalized medicine, and then we have like say a person specific therapy. So likewise in yoga or meditation, you talk about this entity exists or not, meaning all yogas are fit for everyone or some yogas are not so. Maybe can you just say a few lines about that? Thank you.
Absolutely. Actually, if you look at it, there is in recent times, there have been reviews which have looked at actually the flip side of yoga and meditation. So people have looked at actually how in an improper way it can cause on one hand physical surgical injuries, and on the other hand how meditation can also have negative impact. So you are absolutely right. And therefore, as medical people, if we want to use it in a therapeutic sense, see, we know that yoga has also been used for multiple purposes. People have used it to promote their own health. People have used it for spiritual pursuit, so on and so forth. People have used it for many different purposes. So a fit person taking to certain activity, a fit person who is in a fit health, taking to some activity, tolerating that activity is a completely different scenario, compared to when we are trying to do it in a patient population. It's not only the efficacy, but safety also becomes very important. And if you look at it, there is a lot of literature which is coming in now, which is pointing towards that. And as an individual basis, I have seen plenty of patients, who tried to actually do yoga on the lines on which fit people try to do, and instead of benefiting from it, had experienced problems with it, which is understandable. And a lot of people who are into the traditional practices of yoga, unfortunately, obviously, I don't blame them because they have had no medical training, so they are not really aware as to what are the limitations of this patient and what is the basic pathology which this patient is suffering from and what should be the approach. So therefore, I am a strong proponent that the medical people should have understanding of it, something like, as we say, the orthopedician and the physiotherapist kind of a relationship. A person who is a yoga person working under the guidance of a medical person who has an understanding of that whole process. Maybe the orthopedician doesn't do the physiotherapy, but orthopedician knows it well, what it's to be done with that. So rather than yoga therapist independently sort of administering interventions to patient, I think we would be better off in a supervised kind of a work scenario, more effective and safe. That is what I would say, from my personal experience.
Thank you so much, Dr. Sanjay.
Thank you.
It was very nice talk.
Yeah. Thank you. Go on, can you take it forward, please?
Thank you very much, sir. Sir, do we have any time for questions? Because it's time for the global MND awareness.
Yeah, please go ahead. Please go ahead. Yeah.
Okay, thank you very much, Dr. Sanjay, sir. That was in the current era where both the patients and the scientific forums actually asked for evidence. You actually spoke the language of evidence for the yoga and told us how beneficial the yoga is, so every one of us could understand it. And thank you very much for your wonderful brief talk on yoga and brain health, sir. So let us next proceed further with the panelist for the Global MND Awareness Day. So we have an elite panel from across the globe from 3 continents. So let me introduce the neurologist in the panel, Dr. Vinit Jason. He is a professor and lead consultant, Neuromuscular Center of Excellence, Department of Neurology from the prestigious CMC Ludhiana. His area of interest is neuromuscular and neurorehabilitation. He has over 10 original studies that has been published and 2 chapters on amyotrophic lateral sclerosis. And he also received the Young Neurologist Award in Turkey 2014. Next, we have Dr. Mohammad Farooq, who is a senior principal scientist from the CSIR IGIB, the geneticist. His area of interest is neurogenetics, specifically with an induced pluripotent stem cell-based disease model with over 100 publications. He also received the CSIR Young Scientist Award 2015 in Biological Sciences. Next, we have Dr. Sangeeta Madhavan from US, and she is the lady with the neuromodulation hands, the physical therapist professor from the University of Illinois at Chicago Neuro Rehab, and with over 72 publications and 100 conference symposiums and posters. She has several awards to her name. Next, we have Dr. Suresh Kumar from London. He's an occupational therapist, associate professor at the Northumbria University and PHFI. His area of interest includes disability, public health, health system, and policies. He has over 65 publications in peer-reviewed journals with several awards to his name. Next slide, please. Next is we have Dr. Ankita Buttada from US, who is a speech and language pathologist from Asant Health System, US, with over 12 international publications. Thank you for joining us. Next slide. Next, we have the chief dietitian, Ms. Bhakti Samant, ma'am, from the Kokilaben Dhirubhai Ambani Hospital and Research Center, Mumbai. She is also the honorary joint secretary of the Indian Association of Parenteral and Enteral Nutrition from IAPE and Mumbai chapter. She is life member of various associations, has several certifications with relations to nutrition, and is a specialist in clinical nutrition. Next, we have Ms. Satvinder Kaur, who is the co-founder and director of ALS Care and Support Foundation. She is also an associate director in Kyndryl IBM. I thank the esteemed panel for joining us on this Global MND Awareness Day to answer the questions and address the public health concerns for the public, patients, and the caregivers. So let us start with questioning our elite panel. So first, motor neuron disease, which has been abbreviated as MND, according to the Indian data, can affect individuals right from 23 years of age up to the 70s. And compared to other neurodegenerative diseases where the treatment is, there is paucity of treatment, such as the Parkinson's disease, Alzheimer's disease, this MND, which starts relatively early, can strike at the prime time of the life. And with limited therapeutic options and unable to offer a complete cure at present, it significantly impairs the life of the patient. And we keep hearing about motor neuron disease and amyotrophic lateral sclerosis, sometimes interchangeably. So let us hear it from Dr. Vineet Jason, the neurologist in the panel. Sir, can you tell us about motor neuron disease and how is it different from amyotrophic lateral sclerosis, and what are the clinical symptoms of ALS?
Thank you, Guhan. Thank you for this opportunity. So motor neuron disease basically is a group of disorders that affect the corticospinal tract in the central nervous system and also the anterior horn cell. So there can be a spectrum of disorders. If they affect primarily the corticospinal tract, then it could be called primary lateral sclerosis, or if it is affecting just the anterior horn cells, then it could be a progressive muscular atrophy. If it's affecting the craniospinal or the bulbar area, it could be progressive bulbar palsy. Or if it is affecting both corticospinal tract and the anterior horn cells simultaneously, then we call it amyotrophic lateral sclerosis.
Thank you very much, sir. Can you highlight what are the symptoms of amyotrophic lateral sclerosis?
So because of its biology affecting mainly the corticospinal tract and the motor system, the patient has symptoms affecting the executive system or the outflow or the muscles or the motor system. For example, the patient may have, if it is affecting the foot, the patient may have thinning of the limbs, patient can have flickering of the foot, patient may have pain also at times with cramps in the foot, but they don't have any sensory loss in that limb. And the hands, similarly, it can begin with thinning of the hands. It can begin with difficulty in holding objects. Things can slip from the hands. And then if they have involvement of the respiratory system, they can have easy fatigability, breathlessness, tiredness, and that is something that can often get missed. A certain percentage of patients can begin with just respiratory involvement, the muscles that affect the breathing, that can get affected. Also, if the patient has involvement of the bulbar area, they can begin with speech problems. Not in understanding of speech, they never have difficulty in understanding or comprehending or feeling or touch, but they have difficulty in speaking. They have difficulty in articulation. They have difficulty in being understood by their peers or their caregivers. And also some percentage of patients may have some degree of cognitive challenges. So these are the main symptoms with which a patient may present to us with ALS.
Thank you very much for the brief answer, sir. So predominantly ALS and MND, we are able to get a much more clear picture that ALS is one type of the motor neuron disorders with predominantly a motor manifestation affecting the speech and so on. Thank you so much for that answer. Wonderful answer, sir. Next is to our scientist and geneticist. The physical traits can be passed from parent to the offsprings through the genes, and that has been portrayed in many movies across many languages. And it is the fault in the genes that can result in various diseases. Now, with the advances in genetics that we have seen like never before, let us ask our genetic expert, Dr. Mohammad Farooq, sir. What is known about genetics in ALS?
Yeah, thank you, Dr. Gohan, for the wonderful question. And I just want to begin with that there is a due importance we need to pay towards the genetic understanding of ALS. As we have learned from Dr. Vineet, that there are, like, say, different types of MNDs, right? There is corticospinal tract, there is anterior horn cell affecting ALS, and there is combined, and there are many more. And not all patients, even within one subtype, behave similarly. So basically, there is a everywhere. I think we talk about cancer. We have recently just handled this COVID thing. We discussed about what, like, the genetic variants, right? There are types of COVID variants. There are different mutating COVID variants, and likewise they had maybe role in the the COVID outcome or not. We are yet still studying that. So likewise, here in this part of country, we need to pay a due attention towards the genetics of ALS. And when we talk in essence about the genetics of ALS, I think till date, there are, like, say, 25 odd genes and have been identified where the defects in them, they are definitely are linked to the ALS phenotype. And you can say there is some similarity. If I have to just correlate, maybe that's one disorder we all know, spinal muscular atrophy. There is a strong genetic basis, basically. So that's also a sort of a severe variant, you can say, of the motor neuron abnormality. So maybe ALS is another sort of a late onset variety of this motor neuron involvement. So here also, ALS also, we suspect that there are definitive genes, and the role of them is so far have been dictated by investigation and by research, such that 10% of ALS is familial, all right, and 90% is non-familial. So among familial variety, 70% of familial ALS has definite cause in gene defects. So there are 25 odd genes, and there are, like, say, not all genes are equally common. Some genes are very commonly observed, like suppose you have a fever and the causes of fever, and you have different etiologies, different causes of fever in different time point, different geography. So likewise, this genetic defect also has a different proportion. Sometimes these are genetic events, right? So there will always be an ancestor which has established the descendants, which has that mutant. So basically, depending upon that founder of that mutant, the geography may have or may not have certain mutation. So some geography has more mutation of one variety, others may not have. So not all are equally distributed. So saying that, so again, coming back, so I said 10% of ALS is familial, meaning you have more than one member of the family affected. And of that, if we investigate them genetically, 70% will be able to find genetic defect. And among the non-genetic one, there is the non-genetic, meaning non-familial one. People, we believe that mostly, since it's a 90% of proportion is non-familial, so people tend to think more of non-genetic causes, and they undergo a lot of testing and etc. But we see that with available knowledge of these 25 odd genes, they together explain almost like 3 to 10% of non-familial ALS also. So basically, these are like, say, these current statistics, and knowledge is ever like increasing, evolving. And this is just a recent knowledge. The first gene we identified, that was in 1993, that superoxide dismutase. And until 2011, meaning you can say 7 plus 11, 18 years, we knew that 5% of ALS is genetics. But now there is one more mutation identified in 2011. There is called C9orf72 mutation. And that alone explains 7 to 10% of cases of genetic ALS. So I think these are, like, say, some common genetic defects which we observe among patients. And in this country, we require a lot of these genetic investigations to happen, and should be made a practice in clinics. That's what my opinion is about. And also we have to sensitize, increase awareness about this all, and genetic counseling should offer to all the patients and clinics, and then patients should be made aware about all these diagnoses as well. Yeah.
Thank you very much for the beautifully crafted answers, especially your comparison with the COVID mutant, so that it enables the public to understand it better. Like the COVID had various mutants. Likewise, here in familial ALS, there can be various mutants in the genes, and that can result in ALS. And there are 10% of the ALS patients have familial tagged to them. Thank you so much for the wonderful answer, sir.
Guhan, before you take further, we have President of Indian Academy of Neurology, Professor Gagandeep Singh here, and we welcome Professor Gagandeep Singh. Gagan. So it's been a great honor to have him here. I request him to say a few words. Are you there, Dr. Gagan? Yeah.
Hello.
Yes, sir.
Hello.
Yes, sir.
Thank you, Dr. Nirmal. I must congratulate everyone on board here for thinking about our people affected with motor neuron disease. This is indeed a very significant proportion of care which is provided by neurologists, but it is neglected to quite an extent. So I'm extremely grateful, extremely happy that all of you have got together for improving the lot, if I may say, of so many of people in this world who are affected with motor neuron disease. There are many new developments which have taken place. There is a new drug, I believe, which was approved very recently by the FDA, but it is helpful only for a very small proportion of people with MND. So likewise, there are many new advances and many new things that are happening in terms of rehabilitation, in terms of diagnosis, in terms of treatment. And therefore, it's a very good opportunity for all of us to get together for the benefit of the entire community of people with motor neuron disease, increase awareness about this disease, talk a little bit more about this disease, make its early recognition, appropriate treatment, rehabilitation, ongoing treatment, physiotherapy. We don't need to lose hope. Neither do the doctors nor do the people affected by motor neuron disease ever need to lose hope. So I think this particular symposium is very timely. I must again congratulate everyone for this wonderful effort and wish everyone the very best in their endeavor to take care of those afflicted with this disease. Thank you so much. Thank you.
Sir, before you leave, today is the International Yoga Day, and Dr. Phadke has talked about the brain and yoga and how the neuroscience is in the yoga. It has been celebrated all across the world. And I would also like to hear from you that your comments on how yoga is slowly coming with various neurological disorder, and what do you think that its future it is going to play a role in our chronic neurological illness?
Thank you, Dr. Nirmal. I think yoga has come to stay in this entire world, and that is thanks to the push and the importance and all that has been done by our country and our country's Prime Minister. I think yoga today stands as one of the important modalities of improving our physical, mental, and spiritual health. And I think it is on all three counts. It's not just spiritual health, it is the physical health also. And there are many counts. There is huge amount of research and which has taken place where yoga really helps. It's a kind of discipline. It is a kind of lifestyle which is adopted. And I think this is something that India can offer to the entire world. And I'm very positive about yoga, and I'm very positive that yoga has come to stay. It has found a place in day-to-day life across the world.
Thank you so very much for taking out time from your absolutely busy schedule as President of Indian Academy of Neurology. But it is important for all of us, members of IAN, and especially thanks Dr. Sanjay Phadke, who gave a wonderful overview on the yoga and the brain. And thank you so much. Guhan.
Thank you.
My sincere thanks to our President IAN, Dr. Gagandeep Singh sir, for the wonderful words on yoga and the MND to increase the awareness further. So continuing with our panel discussion. So ALS is a disease in which the most prominent manifestation is loss in motor power that is very disabling to the patient. And let us ask our neurophysiotherapy expert, Dr. Sangeeta. Ma'am, what is the current physiotherapy management for ALS that would help augment the energy bar for these patients?
Thank you, Dr. Guhan. That is a really good question and something that I think we're still trying to figure out a little bit. As the presenters before me mentioned, Dr. Jaisen and Dr. Farooq, you highlighted how ALS is really different. It manifests in different ways. The origin is also at different levels. So when it comes to physical therapy and rehabilitation, it's more currently right now, it's about symptomatic management. So when a patient comes to the clinic, it's more about understanding where their level of motor neuron loss is, what type of functions or what sort of impairment do they have, and then to proceed with physiotherapy accordingly. But one of the things that we've also been looking at is looking to see whether aerobic exercise is an effective modality or not, because as you know, this is a little controversial in ALS in terms of whether exercise is a prescription for people with ALS. But more and more research is coming out. And in fact, there is one latest study, it's a meta-analysis, meaning it has looked at several different studies over the last 10 years. And this highlights that indeed exercise might be a good option. So when I say exercise, it could mean several things. We're talking about low intensity or moderate intensity exercise, like taking a brisk walk, nothing too high intensity at this point, because we don't know if high intensity exercise is good or not. But for ALS patients, one of the things I would recommend is doing something low intensity, which gets your heart rate up, but not too much. So the reason I talk about heart rate and getting the cardiovascular boost is it's not just because for your heart, but it also helps the brain. So more research is showing that aerobic exercise can also boost brain plasticity, which means the way the brain functions, how neural circuits in the brain are protected. So exercise gives a neuroprotective effect as well. So it's not just targeting the general body, but it's also targeting the brain in trying to keep the brain circuits healthy. So that's one of the first recommendations in terms of exercises, doing something brisk, but also keeping in mind what the level of the patient is. Can they walk? Can they maybe do a yoga routine, which kind of helps increase their heart rate a little bit, gives them a little bit of stretching, helps regulate breathing, which is again important in people with ALS. So thinking about exercise more so, how can I move, or trying to incorporate mobility would be the best way, would be the best recommendation, more so for slowing disease progression and also preventing physical impairments.
Thank you very much, ma'am, for the question the patient usually asks, that is, I'm unable to do anything and is exercise advisable for me? The right answer would be a moderate intensity or a low intensity exercise that could keep the heart rate up, but not so very intense to disable the patient. Thank you so much for the wonderful answer, ma'am. And as stressed by our neurologist earlier, Dr. Vineet Jason, sir, ALS affects the individuals beyond the motor power and affects multiple parts of the neurological system. Like we will be seeing further that it can also affect the speech, it can affect the swallowing further. And so let us ask Dr. Suresh, our occupational therapist in the panel, a question a little away from the occupational therapy, but what must be the focus of the multidisciplinary team when it comes to ALS, sir?
Thanks, Mohan. Very important question. The focus should be on function, and should be on the needs of people who are actually experiencing the problem with their caregivers. To do this, my primary suggestion would be to look at a very precise, specific assessment of the needs of the person who is actually experiencing the problem, rather than focusing more or heavily on the clinical aspects of ALS as such. So if you have lots of standardized assessments to look at the clinical aspects of someone experiencing ALS, compared to just asking him one question, what do you want to do after going from here? It makes a tremendous difference. And I believe that the focus should be on the latter, looking at what are the felt need of the person experiencing the problem and the caregivers who are kind of supporting this person who's experiencing ALS. And it's not very easy to kind of understand what they mean, because we have a multi-cultural context in India, and people have different needs. People have different ways to actually meet those needs. So it's highly essential to be very intensive in terms of looking at what exactly are the needs, what do they define by these needs, and focus more as a team together, despite the barriers that we have to work together as a multidisciplinary team.
Thank you very much, sir, for highlighting the important aspect that don't just look at the deficit, but also look at the functional translation. So the function rather than the deficit is more important. Thank you for the wonderful point, sir. When we see these patients with motor neuron disease, their speech is affected and unable to provide a restorative solution. And at this point, the treating physicians are in a fix, hence we resort to compensatory strategies. So to the speech and language pathologist, Dr. Ankita, ma'am, what are your thoughts about the role of speech and language pathologist in proactive swallowing and respiratory rehabilitation in ALS?
Thank you, Dr. Guhan. That's a wonderful question. So like Dr. Madhavan touched base that there has been a shift in the trades where especially the low intensity, mild to moderate exercise have been kind of starting to pick up. So especially on the similar lines based on the limb literature, also in the speech and swallowing literature, they have seen that instead of restorative, proactive treatment has been found to be useful. To put it in simple terms is to use the functional reserve. So what I mean by that is, like, let's say you're earning 100 rupees and that's enough for you to meet your family needs. But now if you are able to get something extra, let's say 150, so that 50 rupees is your additional balance that you have. So when ALS, which affects the reserve, if you have these extra reserve with you by doing these exercises, so the disease that affects, you'll be able to use your functional reserve and then prolong the regression that happens. So especially low intensity, moderate exercises of respiratory training, such as building up the expiratory muscles and the inspiratory muscles that protects the airway protection mechanism, have shown to be useful. So that has been the recent trend. So especially recognizing what the patient's FEV level is, or also based on the ALSFRS scale, where they are. And starting these early exercises would just slow the regression. So I believe that this has been the new change. And depending on what the severity is, it is shown to be beneficial for the airway protective mechanisms, especially for swallowing.
Thank you very much, ma'am. Are there any simple exercises that a patient with ALS can use before their respiratory involvement to build the reserve that you would suggest for them, ma'am?
Absolutely. So depending on where the status is, a speech language pathologist would assess how their functional capacity is. So recently, and especially this one research, which is a randomized controlled trial that suggested using an expiratory muscle strength trainer. And this means it has pressure, and this can vary. So they even have a low intensity one, which potentially can be useful for patients with ALS who are in a greater decline, and they have difficulty even to maintain that lip seal. So using that low intensity expiratory muscle strength trainer, which is like an EMST 75, can be beneficial.
Thank you very much for highlighting the importance of low and moderate intensity again, ma'am.
Yeah, thank you.
Next is one of the important survival instincts in life, that's food. In the current era where it is very easy to find food, but actually very hard to find healthy food. So nutrition becomes very important for every one of us, and more so in the current context of today's discussion for the patients with ALS. So let us learn from Mrs. Bhakti Samant, the dietitian in our panel. Why is nutrition important in patients with motor neuron disease?
Yeah, thank you. Thank you so much for the question. I hope I'm audible.
Volume is a little low, ma'am.
Yeah, can you hear me now?
Yes, ma'am.
Yeah, okay. So I think first and foremost, like all the experts mentioned about motor neuron disease affecting the nerves, which is going to affect the muscle. And when we talk about muscle, it's not just a specific part. We are also looking at muscle loss or weakness or, wasting, which we see, which is very common in motor neuron disease or any different, diseases that we are looking at. So here, one of the major reasons is that it is a catabolic state where the requirement is as it is high. Secondly, due to the loss in the muscle, the swallowing capacity is also getting affected. The motor function is also getting affected. So that again, in turn, is going to, cause a decrease in the overall food intake. So in totality, we are fighting catabolic state where the requirement is high. And secondly, my intake where I'm not able to meet up even my regular intake, that is where weight loss gets in. So as we know, there is no treatment. I mean, we are not going to cure this condition. We are only going to support the patient to get through a good quality of life. So I think that is where nutrition, plays a very important role. And sadly, I think though it is our survival instinct, but I think a patient would never first go to a nutritionist whenever he's going to be diagnosed with this condition. He'll go to all the experts, and I think the nutritionist or the clinical dietitian is going to come into play only and only if one of the doctors have suggested that, no, it's time that you go to a nutritionist. So I think this awareness, I think this program is, I think the need of the hour, because it's about creating awareness. And there are so many different specialists, some of them I am seeing for the first time, and it's wonderful to be a part of this panel where we can, highlight the role of nutrition. And we know that it is in these cases, the mortality, the quality of life, it's all going to be affected when we see an increased weight loss. So I think that all of that signifies the importance of nutrition. So, yeah.
Thank you very much, ma'am. So the summarizing ma'am's views that the catabolic state along with the dysphagia that the patient develops further results in the muscle loss, and it's all the more important to optimize nutrition for these patients. Thank you, ma'am. And now in lines with the quote, every great act is made up of small deeds of serving people. ALS Care and Support Foundation has been ever thriving and joining hands with a lone soldier who fights the disease with a view to enrich their lives and have touched their lives, the lives of over 500 patients with ALS. Let us hear from Ms. Satvinder. What are the common challenges that is faced by patients with ALS, and what kind of solution or support does your group provide?
I'm audible?
Yes, ma'am, very much.
Thank you so much for having me part of this esteemed platform, first of all. So thank you, Dr. Nirmal Surya, for accepting the request for having this kind of event. And it's a great thing. I think first time ever, I am not aware that earlier something of this sort has been done in India. So I'm really thankful to Dr. Nirmal Surya for getting this schedule for, and this would remain it for, I'm sure, with any replace to play. So we have all the experts here who have talked about the challenges related to, I'll not talk about much on the challenges on the disease side of you, like balancing issues, the swallowing issues, speech issues, and ultimately breathing issues, which is most critical. I would like to share some of the challenges from the practical experience of the many families, which I come across when people come to us, they join our group. First is the diagnosis delay. So misdiagnosis. So people are hopping from ENT doctor to ortho to pulmo, but they are not reaching to the neurologist on time. So when they come to us, they are already past, they have already, the weight is lost, there's a lot of advancement which has already happened. So right, the metros areas of the India, it's still going good that people are able to recognize and diagnose the disease in time. But in rural areas and the small cities, it's still taking a lot of time. Secondly, it's an emotional and psychosocial issues. The setback the family and the caregiver face knowing that the disease is only going to worsen and there's no treatment available. They are fighting alone. And most of the time, patients share that there is a sensitization needed from the medical side when they've been diagnosed. So they need to have that support, the comfort given by their medical side of it. Now come the financial side of, which is financial side of challenges. Like every stage of the ALS requires, as we know that it's a symptomatic management. You require assistive devices like some intervention like walker, wheelchair, motorized neck support, motorized wheelchairs, neck support. You will need supplements so that the weight is not lost. When the feeding gets affected, then you should know that feeding tube needs to be placed. When is the time to go for the BiPAP, ventilator, suction machine, oxygen concentrator. So this disease is quite financially draining for the families. And being part of the patient support group, so these are the different challenges. If I keep on going the challenges, the list is endless. But being part of the patient support group, they feel like home. Everyone is sharing their learning and collective knowledge from each other and making them informed and take the right decision at the right time. I know many cases in our group who said that they've been to their specialist, and even if they lost 30 kg of weight, they have not been advised the PEG tube in time. So these are the practical things which at every stage, we as a group make them understand. And each one person is actually hand-holding each other that these are the things, these are the stages which are coming up. And these are the stages you need to get equipped with, means you need to get ready with. So from each other, they understand what to do in the day-to-day challenges, like issues in drinking water. One can use water thickeners. Unable to walk, you have the walker, wheel support, wheelchair, and also the commode. The portable commodes are available. Even the people who are financially good, they can buy that lifting hoists available to move the patient from a bed to toilet. So as far as the financial stability is concerned, they can not exactly this, so they can go for any kind of devices. When the feeding gets affected, they can go for the grinding of the food, adding supplement, and then there's a time for right decision of PEG, BiPAP, or even tracheostomy. So also, even the people the patients who are not financially good, group members are paying and contributing from their own pocket for these patients and buying them BiPAP, the devices. So this is a part of, I think this is a kind of whole family-like structure which ALS, our group has. Not only, I think this is only the guiding light in every country, the patient support group only. That's the major support for the patients. And I can keep on going on this. So which brand of the device, which contact is required. So you can go on and on. You can get any kind of assistance, how to set up those devices also. So we all have become an expert in the technical devices also. So which kind of mode is required on the ventilator? I've seen people have been put in the ICU CPAP mode, while in ALS, we should opt for BiPAP ST. I'm using this platform to let everybody know about it, that we should go for BiPAP ST mode in ALS patient with an AVAPS or IVAPS on. And I can discuss in detail if somebody would like to know and understand offline. Also, that critical transition stage where most of the people pass away if they don't handle it, it's understanding that breathing difficulty. And that is the key. And one can know that from identifying through pulse oximeter while the person is awake. Anything below 96 is an alarming thing. And while person is sleeping, which is the most important to check in the pulse oximeter. So anything below 93, one needs to buy oxygen concentrator, BiPAP, and suction machine, and also one very important machine which most of the Indian side of it is not aware, which is cuff assist machine. It really helps for a person to live longer without tracheostomy. And even after tracheostomy, this machine is really helpful. So I think this list is very long, the way the whole group is helping each other. And that's all I want to share.
Thank you very much. You have been rendering wonderful support to all these patients, ma'am. And to the chair and convener, Dr. Nirmal Surya sir and Dr. Abhishek sir, Ms. Satvinder had requested to share a movie, and request your permission. Should we share it at this point or towards the end, sir? Can we share it now, sir?
You can share, so if somebody has some question, they can come out.
Okay, sir.
Hello.
Are you able to hear the audio?
Not yet.
45 minutes.
No.
Yes, it was coming up, but it just dropped.
To all the warriors, be happy, keep smiling.
यूं ही कट जाएगा सफर साथ चलने से कि मंजिल आएगी नजर साथ चलने से यूं ही कट जाएगा सफर साथ चलने से कि मंजिल आएगी नजर साथ चलने से यूं ही कट जाएगा सफर साथ चलने से कि मंजिल नजर साथ चलने से ना कोई परवाह है खुशियाँ हो या गम।
Thank you so much, Dr. Guhan, for playing this video and allowing us. Thank you.
Thank you very much for the wonderful video that you had given us, and for the permission by Dr. Nirmal Surya sir and Dr. Abhishek sir. So, just a second. So now coming back to the panel discussion. So in a disease like ALS, it is not only hard for the patients and the caregivers. Given that the treatment options are very limited, it becomes very hard for the doctor to convey it to the patient that is breaking the bad news. So let us ask Dr. Vineet Jason, sir, how do you break the bad news in ALS? Sir, your mic is muted, sir.
That's a very difficult question to answer, and I think it's a challenge for all of us. And I think there's no real perfect way to do it. There are guidelines which have been published as to how you should break the bad news in ALS. I can probably touch upon some of them. But in a busy OPD with a busy clinic, many doctors in India find it challenging. But even then, it is very important for us to understand what the family and the patients are going through, especially when we are giving them a life-limiting diagnosis. Not just ALS, any such diagnosis where we know in the next few years they will become severely disabled. So the guidelines are this, that it should be a private space. It should not be discussed on rounds or by the patient's bedside or, in passing. That's no place to break the diagnosis of ALS. It should be in a closed room, preferably well lit. The guidelines even go to the details of saying that there should be no desk between the patient and you. It should be a very, non-threatening environment. We should ask the patient if they would like to have a caregiver with them while we tell them about the diagnosis. There should be no interruptions as we are breaking the diagnosis. We don't need to tell them everything up front, but we need to give them the gist of what we have come to know. Also, once we have confirmed the diagnosis, and often set a follow-up meeting on that. And ALS, we know it's very hard sometimes at the first meeting itself to be 100% sure that this is motor neuron disease. And it is often a diagnosis in evolution. So we need to tell them that this is a possibility. However, time will tell us better. We are investigating for other mimics of this disease, and those diseases have better treatment options. At the same time, we must say that even if it turns out to be motor neuron disease, we are there with you and we will journey with you and help you through every part of this disease. And whatever challenges come, there are treatments and drugs available to help you manage those challenges. And as treating physicians and doctors, we will be with you till the end, helping you along the way. So there is no perfect way to do it. Like I said, all of these demands time. You have to spend time with the patient. You have to make the patient comfortable. Sometimes it is not enough to break it in one session. You might need to do it in multiple sessions. In India, we have this tendency where the relatives come and tell us, please don't tell the patient. You tell it to us. Don't tell them, their heart is too weak or dil bahut kamzor hai. But I think everybody would want to know if they have a life-limiting disease or few more years, so they could make those years meaningful and live it to the maximum and create moments and memories that they can cherish. Another very important aspect of breaking the news is also to discuss the disabilities that may ensue, especially the communication disorders. It is very important to preemptively, if possible, to do voice banking, because once the patient becomes very disabled and unable to speak or communicate, that is a very distressing and frustrating part of being locked into your own body. And even for caregivers, that becomes very challenging because they're not able to hear their loved one's thoughts, and using, communication boards, all of those things become, they're suboptimal. We would want to hear a person's voice. We would want to know what they're thinking. And even though they are bedridden, it helps to communicate. So preparing them for things yet to come is also a part of caring for them and breaking the news as to what is going to happen. So they can be wise about how they spend their time, spend it meaningfully. And at the same time, do not take away hope. I think that is very important. Sometimes, they say, ALS means 3 years, bulbar ALS means 2 years. It's like a death sentence we want to give to a patient. And we know we cannot be sure. ALS itself is a disease which has got variable progression. Sometimes it may progress rapidly for a time and then plateau and then may progress later on. So we can't really predict in individual patient how long, what are they looking at. But even so, like I said, let us not take away hope. And there's so much of research happening. This also needs to be told to every patient that there is research happening. In the last few years, there have been so many new medicines that have come out for ALS. And the way the research is going, we are quite excited that many new drugs will also come. So, I think that's how I would break the bad news.
Thank you very much, sir. That is actually wise words of wisdom from the experience to young neurologists like me. We learn a lot from such wisdom, sir. Thank you very much for the kind words, sir. And now back to the genes that make us. We have heard from the genetic expert that genetics play a role in ALS, especially the 10% of patients who have who happen to have the familial ALS. So let us ask our genetic expert, Dr. Mohammed Farooq, how can the patient know about his genetic component in ALS?
Yeah, thanks. Actually, it's a pertinent question, and I think what it is like that it has to come from this side, meaning the experts, and they can guide them very well. And as I said, like for any disease, you have not one cause; there are many causes. So, like when we talk one particular cause in ALS, genetic causes. So I already said that there are 25 odd genes which we know as the definitive causes of ALS, and more they segregate with familial cases than the non-familial cases. But still, as I said, knowledge is evolving, and we need to go more deeper into them. And like it is not just done at the laboratory level, but at the research laboratory level also. And for that matter, like say routinely, as I said, like there are the geography affiliations, and then there are sometimes communities where a particular genetic defect is getting segregated, and we have less knowledge about that in India. But in time to come, we will know more about those genetic defects. And so what we need to know is that, like when I talk about genetic tests, so the usual modality is that there are common ones. There are 6-7 genes which are most common one among genetic varieties of ALS. Superoxide dismutase 1, then C9orf72, TAR-DPP likewise. So the way to get these tests done, so some hospital may have their own laboratories, and otherwise there are commercial laboratories available, and which can offer the test on the specific manner. There are few genes which they test, which we call as panel. So the few genes in a panel get tested, Or on the other hand, like say there are now the cost of sequencing. Sequencing is the method by which we read the DNA sequence and we get to understand where is the defect. Meaning it is we compare when we do test a patient sequence, we compare it with a healthy person's DNA, and then any defect we identify, we tend to think that whether it is really the cause or it is just a bystander, because in DNA we have a lot of healthy variants as well, which leads to our physiological variability, what we see among each other. So we have to really identify the ones which are the problematic ones. So as the sequencing of the cost of sequencing has come down, there are other tools as well people are going after, and the clinician most commonly favor those sorts of tests like whole exome sequencing. So that is basically nothing but, like say in our entire DNA, we have 20,000 genes embedded, and that test sequence every those sort of 20,000 genes. And you just look at the ones which are the hotspot. We know that these are the common ones. We go first check those genes, and if not, then the rest of the data becomes a research data. So even your research expert or the clinicians, maybe later on, if they want to go for reanalysis, the data will be there available. So that is the most common way of cost-effective testing. And the other way is the cost less cost-intensive would be the panel test. And other than that, there is one common defect which we call C9orf72 that is not done by whole exome sequencing. That requires a special procedure. This is just a simple procedure rather, but it's a specific test. So I think these tests are nowadays, luckily, they are available, and many labs are now equipped to do all these tests. And these are new things. So I think in time to come, everything has to go together, like the diagnostics of the knowns and the research of the unknowns. And we have to seek more and more the investigation for understanding the genetics of ALS.
Thank you very much, sir, for highlighting the importance between the targeted panel testing and the genome sequencing in the diagnosis of ALS. And next would be the recent buzzword in rehab has been neuromodulation, where we can either stimulate or inhibit the activity of the neurons from outside the brain, outside the head, actually. So a few decades ago, what was a sci-fi story is now becoming a part of the reality and is translating from the lab to the bedside into the clinics. And it actually sounds fairy tale like when we hear that we can modulate the brain activity from the outside. So let us clarify it from the lady with the magical hands of neuromodulation, the physical therapy expert, Dr. Sangeeta. Ma'am, what is neuromodulation and how is it useful in ALS? And what is the current evidence for neuromodulation in ALS? And what do we look out for in the future?
Thank you, Dr. Guhan. You aptly put it that it's fairy tale-like. Although it is fairy tale-like in ALS, neuromodulation has been used for several decades in other populations. In stroke, primarily, it has been used for depression. And some of the work we do is actually taken from these other diseases where it has been successfully used. So to go back to your question, what is neuromodulation? So neuromodulation is basically modulating the circuits in the brain, making them more present, making them more excitable, I would say, or inhibitable, depending on the type of current that you're using. So the particular type of neuromodulation that we are using in our lab is called transcranial direct current stimulation, or TDCS. It is a handful to say, but it's actually gaining a lot of popularity. So if anyone Googles for TDCS, you will see thousands of results that are available. What neuromodulation has been used for is, it has been used in the motor areas. So to strengthen these motor tracks, it has been, like I said, used for depression quite a bit. Different types of neuromodulation can decrease depression, alleviate anxiety. It has been used for cognition. So depending on which area of the brain you're applying the current to, it can have an effect accordingly. So the way we apply TDCS is we have these small little electrodes that we place on the area of the brain that needs to be treated. we are a walking lab because I'm primarily interested in walking. And so we target the lower limb motor cortex, which is the area that controls gait. Even though I'm saying electrical stimulation, there's nothing to worry about because these are really low levels of electrical stimulation. It's not like the electrical consult, the ECT therapy that people know as shock therapy. This is very different from that. You can barely feel the electrical stimulus, so it's very mild. You do not get a shock from it. You can barely feel it once you apply it on the head. People report it as, our participants report it as tingling, just little sensations like that. So we place these electrodes on the brain, and the current study that we have, we are actually doing it via telerehabilitation, meaning that we are in the lab and the patient is in their home, and we are able to administer these currents remotely. So which is a great bonus for people with ALS because they do not have to come to the clinic or they do not have to come to the lab for us to provide them these currents. Of course, it's all controlled. We give them a code so they cannot on the device when they want to, but they actually have to talk to us, and we give them the code and then they have the device. So neuromodulation in ALS is relatively new. Like I mentioned before, it has been used for several decades now in stroke. In our lab, we've used it successfully in patients with stroke for a while. So this is relatively new in ALS. I would say the evidence is really low at this point. We are currently, there are a couple of studies which have initially started using this, but given the heterogeneity and variability in patients, given that patients are so different, it's really hard to say which area to target. And also given that the progression of the disease is really different in patients, that also makes it difficult to perform a randomized control trial. So these are some of the limitations in the evidence that is present. But the study in our lab right now, we are completing an NIH-funded study. We've been doing it for the last 2 years, and we have a good number of patients. And we have shown that right now, the electrical currents are safe for use in patients. They're also feasible, which can be that you can do it. It's a 6-month study, so we're actually giving these currents for 6 months, 3 days a week. Most of our patients are able to complete it. We have patients from different parts of the US participating in the study. We are still yet to complete the study to look at efficacy, which is our primary outcome, which is about slowing of disease progression. So that's where we are at this moment. There's one study that has been completed in Italy, which also has good results with TDCS. But right now, I would say we are in the preliminary stages, but it's kind of exciting to look at a device which is clinically accessible because you can buy some of these devices, at least here online. The patient has access to it. There's not much training associated with it in terms of patient, clinician, or caregiver, and it can be done easily in the home. And safety is high, risks are low at this point.
Thank you very much, ma'am. So that's one other avenue to look out for. So we'll be eagerly awaiting your results, the results of your study as well. Thank you so much for the highlighting the importance of neuromodulation, ma'am. So the disability that results from neurological defects in ALS significantly limits the quality of life in these patients. So let us hear it from Dr. Suresh, the occupational therapist in our panel. How do we strategically reduce the burden of disability due to ALS?
Thanks, Gohan. I'm going to take my OT hat and then put my public health hat to answer this question. Primarily because when we look at disability, from a clinical perspective, we only measure disability a lot. And as you heard from the previous panelists, it's very difficult to identify evidence even in high-income nations. And even if you find evidence in high-income nations, reducing disability by translating that evidence back home to India, this is not going to be possible because of the lack of systems that we have, even for a multidisciplinary team in many contexts. So in terms of the way in which we should target it, it should be at a national level.
User, your voice is a little low in between. So if you could come closer to the mic, sir.
Talking in front of a laptop and I don't have a headset. So can you hear me now?
Yes, sir.
Yeah. So what I was trying to say is the issue of neurological disability per se, let alone the disability experienced by those with MND or ALS, should be considered an important public health problem. And the target should not be on some of the usual understanding in terms of which diseases has got the highest magnitude, because we have never reached addressing those solutions even now. Stroke is considered the second leading cause of death for the past 50 years. It's global, it's not just in India. So similarly, rather than looking at the magnitude of the diseases that is there in India, we should look at the public health approach to understanding and identifying the solution through public awareness and looking at social care as a part of the public health approach to understanding and reducing the burden of disability experienced by those with motor neuron disease in general and ALS. This is particularly because we've gone beyond the stage where we are now looking at paucity of evidence on one side, lack of funding allocations on the other side, and lack of government institutions which could provide these care and support, which another panelist was talking about very intensively in terms of support and care through government systems. So it would be great if the responsibility could be taken over by the health systems in the country, and if support and care for managing disability and the disability burden could be looked at from a primary care level to reduce the tallies in the country on ALS.
Thank you very much, sir. The patient finds it very hard and frustrating when he is unable to communicate due to dysarthria or slurring of speech in ALS. So let us ask our communication expert, Dr. Ankita. Ma'am, what steps do you think will help facilitate speech and communication in ALS?
That's a wonderful question, and that's such an important aspect for all of us. Like we all always do chai pe charcha, so talking and eating. Both are such an important thing. So for example, for communication, I think that early on, whenever a patient has been referred for speech pathology, it is important to assess the basic communication needs. So making sure to include some speaker orientation strategies, so that which the speaker himself can use when they are in the early on stage, that is just reducing their rate of speech or working on the breath groups, and also training the caregiver that they can modify their speech in a way that it's more easily accessible. Also early on in the stage, using of these low-tech AEC devices can be very helpful. So low-tech, I mean, is where you do not require a lot of technology. And it's very important to use the systems such as the voice banking, which Dr. Jason already mentioned, and message banking. So what does this mean? Voice banking is whereas speech pathology who is experts with their various phonetic sounds. So it would be an inventory of sounds that you ask the patients to read and record. And then this is being put on an app or a device that will synthesize the speech, and that will help to produce those text-to-speech kind of things. And there is also a message banking where you would like to hear your own own patients saying words, such as if they have to say something to their loved ones. So in message banking, their original phrases are being recorded, and there is again a mobile talker, which is a free app that can be used and that can be utilized. Also, a lot of ergonomics that can be identified if there is an eye gaze based device. So there are some simple apps that can be used if there is no high-tech device that can be available. So early on, if these things have been worked upon, it will help to have the communication even in the later aspects of the life.
Thank you very much for highlighting the importance of voice banking as well, ma'am. Thank you, ma'am. And now next to the dietitian in our panel, every one of us have this doubt in mind. What are the specific nutrients that are suited to me? Now applying the same question to the patient with the ALS. Ma'am, can you comment on the specific nutrients which are of importance in these patients? So, is it just calories or nutrients as well?
Yeah. So, when we're talking about good nutrition, we are going to talk about calories, we are going to talk about macronutrients, we are going to talk about micronutrients, and we are looking at a balance. So if you look at on paper, if you look at the data, what really suggests is one of the prime focus when it comes to macronutrients would be proteins. We Indians normally also are a low protein intake population. Whereas in a condition where the swallowing going to be limited, the intake is getting less, the protein content further goes down, which is what is accelerating the disease progression, as well as, the quality of life, which is getting hampered with the weight loss and all the other associated problems. Another very important macronutrient would be fat, where we are looking at good fats, because that's what is going to give me calorie density. It's a condition where we are talking about oxidative stress. We're talking about inflammation. So obviously, when we talk of inflammation comes our anti-inflammatory foods. So if you'll read about anti-inflammatory foods, yes, there are certain sets of vitamins, vitamin E, vitamin A, vitamin C. We talk about B12, which most of these patients are deficient or have a deficiency. So this is what the data says, okay? And this is what the studies that we have come across will say that, okay, these are the prime focus in terms of nutrients that one needs to keep. But when it comes to ALS or any MND case that we are coming into, first and foremost, when the patient comes to the dietitian, we first do a detailed nutritional assessment. Now, this nutritional assessment, wherein we are going to assess if biochemical parameters are a little haywire, we look at what is the functional capacity. We look at what is the current dietary intake. What is the capacity or the consistency of the food that the patient is able to take in. So even though on paper it will say that I'm supposed to give, say, 30 to 35 kcal per kg body weight, for an average 60 kg man, it will go up to more than 2000 calories. But that's on paper. That's what my RDA says. But when it comes to in reality, what we go by in assessment is that we look at what is the current intake. How much is the patient able to take in? For example, the patient is not able to consume even, say, up to 800 calories in a day, whereas my target is to achieve 2200. Here we devise way where we do a step-up management, where we do by an increase of 300 to 400 calories every time the patient, is trying to improve his intake. We have to rely on supplements. We have to rely on multivitamin supplements. We have to rely on oral nutrition supplements, which are going to be specific as per the demand. Maybe in some cases where I'll have to use a high calorie supplement, in some places where I'll have to use a high calorie, high protein supplement, which is going to be highly individualized. So there are specific nutrients that we are looking at, but here our main focus is how much we are able to step in. Plus, if the swallowing is compromised. Here, I think when a patient would walk into my room and say that, okay, now, we are having a difficulty in swallowing liquids, or there is dysphagia. We, at least from my end, I always try and include the speech therapist or the swallowing therapist, because until and unless there is no clarity which is coming to me from the therapist as to the kind of consistency of the food that I'm supposed to, prescribe to the patient, it's very difficult, because we can go wrong sometimes in terms of the consistency, where in case of dysphagia, aspiration chances increases. So definitely macro, micro, all of that together are important, but our main focus would be on how much the patient is able to take and how much I'm able to step up with the help of the natural diet, with the change in the consistency, at the same time with the addition of the supplementation. But yeah, protein is one aspect, which is protein as well as calories, which are, I think we very strongly work towards trying to correct in, these patients' diet. So that is in terms of the food intake that we are looking at. Yes, antioxidants will come into play. There will be a role of these micro nutrients which are going to come in, but we try and provide everything in a very compact way, in a very concentrated way to the patient, where in the lowest quantity, making it more calorie dense, we are able to provide them with maximum nutrition. That is what is our main focus on.
Thank you very much, ma'am, for highlighting the importance of calories, macronutrients, micronutrients, including antioxidants and everything. And for the next set of questions that I'm going to ask, I have a humble and kind request to all the panelists that since we are running short of time.
Mohan, there are a couple of questions and some people have raised their hand. So I think before you take final round, answer those questions from the chat, and there's two people have raised the hand.
Okay, sir. Yes, sir. So there is one question by Ashish Sharma. Kindly provide details of cough assistive device. So a panelist,
Yes, I can say this is cuff assist device is available from Philips Respironics, and E70 is the model number if I'm not wrong. One can check on Google, check the cuff assist device, and it is somewhere around 2 to 3 lakh. So that's will be very helpful for when to initiate that reflex and people can cough out, and that episode of infection and pneumonia can be avoided for ALS patient. And that is actually the cause of the critical, they falling into the critical ICUs.
And so the other questions, the answers have been typed in. Do I take the questions for verbal discussion as well, sir?
You go ahead, yeah.
Okay, sir.
And some people have raised hand. I don't know what they want to say. If they can ask the question rather than talking.
Yes, 21 plus and Buddhi Rawat. You want to ask the questions verbally?
Yeah, I would like to talk for a few minutes.
Yes,
Can you hear me?
Yes, sir, very much.
Okay, first, thank you. I've learned a lot from you, though I don't need it now. I would like to initially thank Sat. Sat, I lovingly call Satvinder Kaur. I love you, dear. And she was a great help when my wife was undergoing the stages of motor neuron disease. And her group was really helpful. But I will come to some of the points that we have discussed and I'd like to highlight. You see, I have attended many workshops in Bombay during the time when my wife was being diagnosed and going through the process of progression. And everywhere I went, of course, there were eminent doctors of all specialization from different hospitals. But when I spoke about caregiving, everybody stood up and said, "Thank you, sir, you learned something." Because caregiving is something which we live with every day. And as far as the doctor is concerned, it starts and stops the minute the patient comes and leaves. In fact, the Hiranandani Hospital in Bombay, whenever a patient got diagnosed and came to the neurophysician, the lady doctor always advised her or him to come and meet Commander Rawat, that is me, and he will give you all the necessary tips. And luckily, I should live in the same compound, and I used to give them a lot of tips. And they said, "Listen, sir, even the doctors probably are not aware of these kind of things." I mean, it's not a professional thing; it's more of a routine thing. But you kind of develop that, kind of instinct to make things work, which is out of the medical books. A very simple example, my wife was in the later stages when she was bedridden, she couldn't move. There was one index finger which could move. We placed a plate under her and she would write alphabets and spell out words, whatever she wanted to. That was one of the form of communication. And this is, I'm referring to Dr. Akansha, your speech specialist. Sorry, I do not know your name so well. You can advise such small things because these are not part of your medical journals. Second thing, if at night or any time she wanted to attract our attention, since she couldn't move, she couldn't talk, what we did, we put a small 25 paisa coin. That time there were 25 paisa coins, and we put a sellotape on it. The coin was on the lower side of her finger, the index finger, which was working, and we put a small steel quarter plate below it. So anytime she wanted attention, she would just tap on it, tuck, 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 and we knew that she wanted something. Otherwise, it would have been hell. And I think through SAT, we passed it around to all our group, and they were very, very helpful. A lot of them used this technology or methodology and were quite thankful to me. The third thing which some of the doctors mentioned was about various research being done. When I first went to the doctor and he told me about this disease, he says, "Sir, I don't think it's going to happen in madam's lifetime, but another 10 years, 5 years down the line, there'll be enough medicines in the market." So in case anybody else develops such a disease after 10 years or 5 years, he'll be not in such a bad condition as what your wife is going to be. But unfortunately, those 8-10 years have passed and we still have hope and hope and hope. And sometimes we do get a good message that something has been approved by the FDA, but the cost is phenomenal. And I agree with two speakers. One is Sat and another one who said that financial is a critical issue. Some of us can afford it. I was in the services, so a lot of my medical support came from the defense services. But there are a lot of people who really cannot afford it. We need to find some way to approach the government to, if a person, I'm not saying give financial support to everybody, but those who can't afford it, give it to them. You need a ventilator, you need a, suction machine to take out the saliva, you need to change the tubes every day. There are so many cough-assisted machines. You need 2 concentrators, oxygen concentrators, because one cannot run for more than 4 hours. So it's a big financial drain. And there are times we have to take them to the hospital in case of emergency. So that ICU costs, everything. Okay, yeah, we can afford it. Like I sometimes say, probably MND is a rich man's disease, but there are a lot of people who can't afford it. So we need to take up a case like this with the government who can support such people. I have so many things to say because it's been 5 years that we looked after my wife. Sat was nice enough to come with her sister, Sukh, and be with my wife. And, Sat, thank you.
Thank you, Uncle. Thank you, Rawat Uncle. And I'd like to add another innovation which he brought in, which a laser pen, which everybody has been communicated to our group also. That laser pen, when person is on ventilator, Uncle has brought in that innovation and we are using. And there are a lot of others also, but this I want to point it out. Thank you.
Yeah, I pin a laser pin on spectacles, and we, typed the alphabets in bold letters and framed it on not framed, put it on laminated it. And then we would hold it in front of her and she would move her head and, move it to each alphabet. Like it's something like Toby, but Toby is electronic and digital. This was just plain manual. So it was fairly successful, and I used it for some time, and then I passed it on to a lot of other people. And they also used it, and they think it was helpful to whatever extent. But of course, it has its own limitation because the patient should be able to concentrate in that direction, hold his or head up. So there are many things, we can write volumes and volumes, but I thank this group for taking up this case so nicely, and, hope the research departments in whichever country they're in. I asked a question, which I'll just take it up, that's, mentioned about something about, controlling the neuron by the electrical device. Doctor, would it be possible for somebody to buy this and take it to India and then through America, through whatever network, can it be done like that?
Sir, I can answer your question that neuromodulation, TMS, TDCS is actually available in India, but what is lacking is the evidence. So we are actually waiting for the evidence of neuromodulation that it is effective. It is available in India and it's being done for other disorders, but
yeah, you will get far more samples, over there, that the number of people who are waiting to get to do something like this will be far more than probably what we'll have in America. Anyway,
yeah, but we don't have.
I agree. I think, as Dr. Gohan said, I think it has to be done under clinical supervision. It's like TMS and TDCS is approved by the FDA, at least for depression, but it's not approved for other disorders. You can buy the device, but it has to be done under clinical supervision.
Okay. Thank you very much.
Now used only as a part of research.
That's all from us. I'd like to thank everybody. And just that I'm in New York, and I saw one of the doctors speaking with New York background. And so I might just tie up with you and discuss more about it. Thanks a lot.
Sir, do we have time for questions or?
I think they have one more question by S21. I think the last question, then we can summarize the session.
Okay, sir. So since it's up to the final question, I will put it as a futuristic question. And to Dr. Vineet Jason, sir, what is the future of ALS treatment? Is there light down the tunnel? Is there a path-breaking solution in the horizon? What are we hoping for in the future, sir?
Yeah, I think that's the $1 million question. What is the future of ALS? I think it's a very hopeful future. Over the last few years, I'm sure we're all aware of so many drugs that have been looked at, from high dose vitamin B12 coming in, and also with sodium taurocholate and phenylbutyrate being made available. Recently, tofersen from the UK group that has come as gene therapy for SOD1 mutation, all of them FDA approved. So the speed at which drugs are coming into the market for ALS has increased. Of course, all of this is not for every patient. We know that ALS, the underlying biology of the disease, has got many mechanisms, and each mechanism may be at play at the early stage, and it's a different mechanism at play later on in the disease. So the first thing I would say is that it's going to be multi-drug approach, like tuberculosis. It's not one drug alone. We will have multiple drugs that will be working. If you look at all these edaravone, you look at riluzole, they work at different parts of the whole neurodegenerative cascade. So we would want to do precision medicine. We would want to know which particular patient is having which biology dominantly affected, so you can target that and make that your core medicine, and then look at other things. Gene therapy, yes, tofersen definitely proved that the amount of protein produced by SOD1 is controlled, and that's how they got approved just in April this year. Targeting these toxic gain of function mutations by switching them off will be a mechanism. So gene testing is already recommended in every patient with ALS, whether there's family history or not, so that we can look at the basic biology and then target. Neuromodulation is a very exciting field, but again, evidence is lacking, but it is an exciting field and holds much promise. So I think every individual case will be studied in detail, in depth, early recognition of these patients, categorizing them as to what are the primary biological, at the molecular level, what are the problems, and then giving multi-drug approach to improve them. We know that even neuroinflammation is being targeted. Masatinib is phase 2 approved. Now they're going to phase 3 trials by December this year. We'll have the results out. So there's a massive drugs that are coming out, a large series of platform trials with multiple drugs being studied simultaneously. So yeah, that looks like the future.
Thank you very much, sir. So Dr. Nirmal Surya, sir.
Yeah.
Final words on the Global MND Awareness Day from Nirmal Surya, sir, and Dr. Abhishek Srivastava, sir.
Thank you, Guhan. You have moderated superbly. I thank you, everybody, because it's very difficult to get a multidisciplinary team, and that too from across the globe. So you have Ankita here, you have Sangeeta here from different part of the world, and then Suresh coming from UK, and then of course our Indian team. We are always available to match the timing. So that's wonderful. I always say, and Jason has also said that word, that when we diagnose motor neuron disease, in fact, in our heart and mind, it comes that we are writing a death sentence. And therefore, I'm always 3 times extra careful before I really is sure that am I dealing with amyotrophic lateral sclerosis or motor neuron disease? Am I not missing any treatable cause of anterior horn cell disorder? And when I have ruled out all these causes, so, he has rightly mentioned the breaking the news should not be all of the sudden. You should always work out everything. And when you have seen patient, say maybe 1 follow-up or 2 follow-up, and you have seen the progress of the disease, that how rapidly it is progressing, how the way it has been affecting a patient, that may be the time to, start telling the patient that, yes, we are dealing with a situation which is like this, rather than on day 1, you may have made a wonderful clinical diagnosis, but the outcome may be very bad if you are not sure of saying at what time it has to be told to the patient. So it is a dreadful disease. And as Gagandeep said, I was in American Academy of Neurology last month, and there were 2 new drugs. 1 drug has already been launched. There are 2 more trials has been on. And I'm sure some of these drugs would make a difference. As Farooq has also mentioned, genetic is playing a big role. So there are genetic disorder which has been linked, the gene has been linked with this disorder. And therefore, the newer treatment could be linked again through the genes and through the drug. We are very hopeful that these drugs come soon to India so that our patients get benefited. And as Commander said, this would come at a cheaper rate so that those who are really in need get it. Like the cancer drug, Government of India has subsidized, then we should try and do that. At IFNR, we have been trying very hard to convince the government about the neurodisability, not only because of motor neuron disease, but neurodisability because of any neurological disorder. And they should take it as a neurodisability with any other neurological disorder like MS, stroke, Parkinson, and give a benefit to all the patients who have neurodisability. We'll continue to work hard with the government, with the other organization, with the society, and come out with you with the solution, whatever we can provide. We have linked with WRA, so we will also request WHO to help us out in endeavor to develop the newer mode of rehabilitation till the newer drugs are not available to our patients. I once again thank you all and to the Abhishek.
Thank you, sir, for the kind words. And just to conclude, I think we have a very nice discussion on the multidisciplinary team on rehab and MND. Just to add two simple points. Always focus on those critical points in the journey of a person with MND. When he loses mobility, when he loses self-care, when you lose the swallow function, when you lose the respiratory function. So if you can plan the rehab on these 4 points, the critical points, you can actually make your journey much more easier for the family to manage. And second, don't forget disability assessment and certification. Now, Government of India is allowing MND as part of our diseases for disability assessment. GOI provides lot many facilities, lot many help from the government for making the journey much more easier. For example, you get some pension, you get access to multiple organizations. So please get the certification also done for disability. And we have to thank the IAN to give the opportunity to hold this session on the Neuria subsection of neurology, me, Dr. Guhan. We have to thank our IFNR colleague, Dr. Ruya, for taking the initiative forward. And all the panelists, our convener, the AV team to make it successful. Thank you all the panelists, all part of the world.
Just Sunil Narayan wanted to say something. If he is around and he want to say something, Sunil is the convener of stroke subsection of IN. Sunil, are you there?
Yes, Lord, thank you. There was a question.
No. I think, Asmita, if Sunil Narayan wants to say something before we close, you can put him into the panel and ask.
Yes, sir.
Hello, can you hear me?
Yes, sir.
Yes, Sunil.
There was a question regarding the role of BCI in the alternative communication for persons with MND. Ankita, do you want to take it?
Yeah, sure. So I think it's for the BCI again is in a very early developmental stage. It's kind of developing for stroke population, but for I think MND, I am not sure when that would be, but I know there are some upcoming research that is happening. So I think we will be on the lookout of that. But I'm assuming it would be at least 2 to 5 years the way at which we are developing.
I think a simple laser in the spectacles is the best way to communicate with advanced MND. So don't waste any money on that. Just use it.
So I read the comment that it's a disease of the affluent and well-to-do may not be the case of only the affluent, but the point is that even the affluent also find completely helpless or irrespective of the financial status or whatever, people find it extremely difficult to go through those late stages. And I think a country like India with technology experts and sufficient financial strengths should certainly start the opportunities. The same for all rehabilitation
programs. But this disease MND with very often very intact cognition, I have at least 2 patients in the very recent past actually going through the late stages in a completely helpless way. And they were ready to purchase all kinds of gadgets. People like Stephen Hawking lived more than 2 decades, continuing to lecture in Cambridge. Whereas many of our patients, and even well-to-do who are educated and intelligent, are finding it difficult to survive more than 2-3 years. So we have to go a long way, as Dr. Nirmal and Dr. Abhishek were telling that they are very active in the advocacy, but we have to continue to work on this to get more and more gadgets available in the market. They may be costly, but there might be people who are ready to have their hands on them and try to use them for whatever little small pressures or added capabilities provides at this late stages of the disease. Their loved ones will be ready to buy them for them. So I think we should have an all-out focus of all our attention to make these rehabilitatory tools more readily available all over India. And I'm sure that IAN's efforts will be.
Yes, sir. Definitely, sir. And I think now ICMR is running a lot of projects on assistive technology, how to make it low cost in India. We are working with, as an IFNR and subsection, with the ICMR to develop new low cost devices. And I hope in next 5 to 10 years, we'll be able to provide all the technology which is made in India at much more cheaper cost. Thank you for your comment, sir. Go on, we can close the session.
Yes, sir. And I take, towards the end of the panel discussion, I take an immense pleasure on behalf of the Neuro Rehab subsection of the Indian Academy of Neurology and IFNR to thank our IAN President, Dr. Gagandeep Singh, sir, IAN Secretary, Dr. U. Meenakshi Sundaram, sir, and the President-elect, Dr. Debashish Chowdhury, sir. And I thank the esteemed Chair and Convener, Dr. Nirmal Surya, sir, and Dr. Abhishek Srivastava, sir, for giving me this opportunity to moderate the session and also for allotting their time in the extremely busy schedule. And the Indian Academy of Neurology, the panelists for their participation and contribution in the public awareness program, though they are from different latitudes and longitudes, from different time zones. I thank you very much for participating in the panel discussion from their busy schedules as well. I thank the attendees. And I thank the IAN Digital Media, Dr. Bhave sir, and his team as well. Thank you very much.
Thank you. Thank you. Thank you. Bye-bye. Bye-bye.
Thank you.
Thank you.
Bye-bye, Dr. Khan, Dr. Surya. Thank you so much.
Thank you.
Bye-bye. Good
Abhishek.
night.
Very good.
Thank you, sir. Good night.